So, welcome along to today's episode of the Zedu Coaching Corner. I'm your host, Sue-Ann Pascoe. If you haven't yet done so, please subscribe to our YouTube channel. And for all the ultrasound educators out there, you can sign up to our Facebook community, the Focus Educator and Seed Support Network. I want to let you all know that this session is being recorded and it'll be available on our website in the next few days, along with all the previous episodes of the Coaching Corner. And you can find them under the Resources tab at the homepage at ultrasoundtraining.com.au. Feel free to ask questions as we go along, but if you're a bit shy and want to ask questions offline, just let me know and we can come back to them at the end of the session. So tonight's topic, we will be talking about a step-by-step guide to the transvaginal ultrasound examination. In a previous episode of the Coaching Corner, I've covered the fundamental scanning principles for the transvaginal ultrasound examination. Tonight, I just wanted to touch on and review a couple of those scanning principles and then dive a little bit deeper into the communication that you need for a good transvaginal ultrasound, and then talk about the 7 steps I use to perform the ultrasound examination. So we're going to start by going back to basics. And the first thing you need to do is to get your equipment ready to scan. And so my favorite new toy here, or not toy, but my favorite new appliance, if you like, is this brand new Task Trainer foam wedge. We've been making do with some other ones for a little while, and we had a really dodgy one for a while that used to squash and was a bit too thin. But these are really quite firm, and they give the hips enough elevation to keep the patient's backside off the table and to give me enough room to move my hand for the examination. So we usually pop that one under the sheet, and I pop a bluey on top of that. And then I get my patient lying on the bed with their backside right up against the edge of the cushion so that I've got maximum amount of room for moving the probe to get really low down, to get a very anteverted uterus, and also to get laterally to get the position we need for the ovaries. So I have my patients bend their knees and pop their feet flat on the bed. And then I cover the lower half of their body with a very generous sheet so that their knees all the way down to their feet are covered. Now, I get them to put their feet flat on the bed for a number of reasons. If you've got another popular position that's used for this is the frog leg position with the soles of the feet together. But I find that it really depends on how flexible your patient is and how well they can tolerate that position. If you're going to take longer than 5 minutes to do a scan, it can get very uncomfortable as the patient. So I get my patient with their feet flat on the bed. The other thing I do is I get the cord and I pop the cord under their foot so that their foot is kind of supporting the cord so it doesn't drag down and pull me off position. The other reason I have them with their feet under the bed, you can see in this photo on the right, I can gauge the height of my bed. So I stand beside the bed and I can gauge the height of my bed for a good ergonomic position because I have their knees sort of sitting right up in my armpit. And the benefit of this is that then I can support that leg, which means, sometimes if you're there for a little while, their feet can get a little bit shaky. And so that lets them sort of rest their leg into me, and it also supports my arm position and makes for a more comfortable scan. It's not shown quite well in this picture, but I'm trying to keep my elbow in front of my shoulder so that I don't put extra strain on the shoulder. And it's important that you're not leaning over too high, too low, or having your spine not straight. So adjust the height of the bed here so that you're nice and comfortable and you're in a good ergonomic position. Now, I have seen some people will have their patients sitting up in a gynae couch. It works very well. Some people sit to do this exam. I've seen others who kind of place their chair right in between the legs. Now, as a patient, I find that quite confronting. So I like to sort of sit beside so that I can't see under the sheet or, be imposing on their dignity while I'm doing the scan. The next thing we need to do is to get the probe ready. And of course, whatever the protocol is in your place for high-level disinfection, you need to follow that. There are a number of different options, and I'm sure they vary a lot around the world. So We just need to make sure that the probe has been cleaned and is high level disinfected to remove any contaminants so we don't spread anything. And then we apply some gel to the face of the probe, and then whatever the probe cover that we're using, we put that over the top, and then some extra lubricant goes on the outside of the probe. We need an air-free transition from the probe face all the way to the patient's anatomy. So you just need to double check and make sure, run your finger over the end of the probe before you pop it in the vagina so that you can make sure there are no air bubbles. If you have an air bubble under your condom or under your probe cover, then there's no way of getting around taking out that probe and recovering and starting again. So just make sure that you smooth out any air bubbles before you pop the probe into the vagina. Now, there are any number of probe covers available on the market. You can use regular old condoms. I tend to use the non-lubricated kind, particularly for patients undergoing fertility treatment. The lubricated condoms often have a anti-spermicidal gel on them because they're trying to prevent pregnancy. But if you have a population where your patients are undergoing fertility treatment, that's not what you want to do. So I use the non-lubricated condoms and then just apply generous lubricant to facilitate the probe entry. You can get these, they're essentially a condom in a package that says probe cover. So it kind of looks a little better, I guess, and they come in this nice, handy dispensing box. You can buy them bulk, and these are a little bit more sturdy than your conventional condom. They're a little bit thicker material, but they're latex again. But you get, as you can see here, 100 in a bag. They're not sterile, they don't really need to be. And the other option, which I use for my patients with latex sensitivities or latex allergies, are these Eclipse probe covers. And they come pre-lubricated with gel on the inside. And so just before I start the exam, I push that gel right up to the end so that it ends up on the face of the probe rather than all the way up the handle of the probe. And then when you pop the probe inside, you just tear off the wrapping and it's ready to go. Now, when I'm using the Eclipse probe covers, I'm very careful just to make sure that the seam of the probe is running across the face of the transducer rather than along the length of it, because sometimes you just get these little air pockets that poke up in the corners, and then you have a loss of contact and you can't get a very good image. So I do just turn it to make sure that the seam is running across the face of the transducer and eliminate those air bubbles. If we get back to the basics, it's really important to understand which way is which on the screen. And so most of these probes will come with some sort of indication that is your conventional probe marker. And the important thing about that is, if we can remember, the anatomy that demonstrates on the side of the probe marker will always demonstrate on the same side as the screen indicator. So essentially, once the probe is in the vagina, I can't see under the sheet at all. So what I do is I hold onto the probe with my thumb along the length of the probe. Now, these probes are often molded so that your hand has a nice comfortable grip and it feels more natural in one direction rather than the other. But once I grab the probe there and I'm hanging on to the probe cover with my thumb, I don't let go of the probe. And so my thumb now becomes the probe marker, which is quite handy because my thumb aligns with the length of the ultrasound beam always. And then when I rotate into the transverse orientation, the action comes from my wrist so that my thumb as the probe marker is either pointing to the 12 o'clock position for longitudinal or to the patient's right side in the 9 o'clock position. And so you can see here that using your thumb as a probe marker gives you a good reference point while it's there under the sheets and you can't see it. And so the thumb always lines up with the length of the ultrasound beam. The left-hand picture is for the longitudinal image. The right-hand picture demonstrates the transverse orientation. And as I said, that action comes from the wrist. We don't want to just be re-gripping the probe because then it can get turned upside down and then the motion of the probe doesn't equate with what you see on the screen. Now the probe moves, we've got pretty much two moves, and these probe moves are always described in terms of movement of the probe rather than what the anatomy is doing or whatever. So the probe actions is with regard to the motion of the probe. Now, a rocking action is along the length of the ultrasound beam. and rocking will put the anatomy in the middle of the picture. A fanning motion will create the slices, and that goes across the width of the ultrasound beam. So in the longitudinal, rocking will position the organs in the middle of the screen, and the fanning motion will create the consecutive slices to scan through the organ. So if we look at that motion and along with the corresponding image, as you can see here on the left, as you rock the probe, you change the position of the probe relative to the anatomy, and it will center the anatomy in the middle of the screen here. So depending on what we want to look at, the cervix or the fundus, we need to adjust our position by rocking the probe or moving our hand up and down along the length where our thumb is lying. If you have a retroverted uterus, your hand will be up, which puts the ultrasound beam directed posteriorly. And you can see on this image, the fundus then is on the other side of the screen. So if the probe marker is where our thumb is, the anatomy on this side of the screen is anterior anatomy. So we'll see the bladder on this side. The retroverted uterus, the fundus points posteriorly or away from your thumb towards your fingers, which demonstrates with the fundus on the opposite side of the screen. If we fan in longitudinal, we create the slices. So we are scanning from one lateral margin to the other lateral margin of the uterus. So you can see here, as we scan through, you can see us coming out of the fundus and the cervix at the same time, which indicates that we're in a true longitudinal position on this uterus. Now, when we go to transverse, all of those motions are now kind of opposite, but they stay the same relative to the length of the ultrasound or the plane of the ultrasound beam. So when we are in transverse, you can see here our thumb is in the 9 o'clock position, and as we rock, we're rocking along the length of the ultrasound beam or in the direction to and from away from our thumb. When we fan, we create the slices or we create the scan, and so the hand in transverse will move up and down to move through from the cervix to the fundus or vice versa. So rocking, again, whichever direction, whether we are across the tummy or transvaginally, rocking along the length of the ultrasound beam will position the anatomy in the middle of the screen. So in that transverse orientation, we're going from side to side here, and you can see, we see the left adnexa and the ovary there. And then as we rock over to the right side, our hand on the patient's left, we see the right ovary. When we fan, regardless of which direction the ultrasound beam is, fanning creates the scan. So in transverse, the thumb is pointing to the patient's right side and the hand will move up and down, and this will help create the slices and help us scan through the uterus and create that sort of CT effect. So in the transverse, we're at the cervix, and as we move our hand up or down, depending if the uterus is anteverted or retroverted, we scan through the uterus. An important point to remember here is that the probe should only move in one direction at a time. A really common problem that I see when people, especially when you're first learning, is that people have trouble keeping the anatomy positioned in the middle of the screen. And as they move, everything moves. So to fix this, you need to be really conscious of isolating the probe movements and moving the probe in one direction or another. So when we're in the longitudinal position, if we have an anteverted uterus, once we establish the fundus in the middle of the picture, or we've got enough of the uterus in our field of view, we need to think about the height of our hand in relation to its position with respect to the bed. And we need to keep our hand at the same height as we scan through the uterus and move it left and right. So for an anteverted uterus, the hand will be down towards the bed. And for a retroverted uterus, the hand will be higher with the probe pointing towards the posterior so that we can see the posteriorly orientated fundus. And so for the retroverted uterus, you need to be mindful that your hand stays at the same height when it's moving side to side. If you are letting your hand drift in height, then the anatomy will move all over the screen. So, as we move and our hand changes the height, it changes position on the screen. So I've got an example here on the left-hand side. This is an example where as we scan through the uterus, our hand maintains at the same height, and you can see that we go through the uterus in the same plane here. And on this right-hand image, you can see my hand is drifting a little. And so as I'm moving, everything's rocking all over the shop, and I can see that I lose the fundus. And we can't see the fundus. So we haven't completed a successful scan looking through the whole fundus because it's drifted out of the picture. Now in transverse, when we're rocking, if our hand dips, what we'll be doing is either concentrating uterus or cervix, or the fundus of the uterus of the cervix. So here's an example where we stay in the middle and everything stays positioned centrally. But if my hand drifts all over the place, then my uterus is going to rock left and right, as seen here on the right-hand image. So as we're scanning through, you see how it kind of drifts all over the place because my hand is wandering as I'm scanning. Now, this can happen too when your anatomy is not quite plumb square. Now, the textbook has it that it sort of sits in the midline and should be all nice and square, but anatomy in real life doesn't necessarily obey what the textbooks say. And so you can have some patients who have quite a deviated uterus. So the key here is when you find the longitudinal scan plane. So I start in true long on the body and I adjust my position to find where the actual true lie and the longitudinal lie of the uterus is. And then I note in my mind, where is my thumb at? Is it at 12 o'clock still, or is it 2 o'clock or 1 o'clock, or maybe 10 o'clock if it's pointing to the left? But if we just went up and down and the uterus is deviated, we'll get lost. And so once you establish true long of the uterus, you then need to establish that's the axis, and then your movement happens along the axis of the uterus. So there's a quick refresher of the basic scanning principles. We'll now move on to the communication skills that you need during the transvaginal ultrasound. Now, it's really important that we communicate well with our patients so that we can ease for any patient anxiety, increase how comfortable the patient feels, also that we can get the best possible examination with the most useful information that we can. And we also need for our patient to be able to cooperate with us during the scan. So as much as it might be a common test for us, and we might be doing this every other day, there are a lot of patients that we see that have never had one before and who are quite anxious about this test. And many a time I've had patients present where the doctor hasn't explained that a transvaginal exam may be offered as part of the ultrasound examination. Now, the rules in Australia, the transabdominal and transvaginal all come under the one fee. And so, patients need to understand that it's part of a routine test. I have had patients refuse a transvaginal exam because their doctor hasn't mentioned it and they figure that it's a different type of exam, and then they end up incurring a second fee to come back and have the rest of the test done. So it's really important for us to be able to explain the examination well, make sure that our patient can give us their best cooperation, they understand what's going to happen. And this is also really important to protect ourselves from any, bad allegations that might come, because a lot of patient complaints in this field can be traced back to a lack of good communication skills. So when I'm explaining the examination, I'm explaining the why, the how, and the what. Why does the patient need a transvaginal exam? I need to discuss with the patient how it's going to benefit them, and I need to talk through what is going to happen. So the why, we need to explain it's part of the standard pelvic exam. It's included as the same cost here. It might be different in your neck of the woods. Patients need to have all of that information so that they can also consent to the cost of the examinations. We need to explain that there's two ways to do the exam. We can go across the abdomen and through the bladder, which means that the organs are quite deep and far away from our probe, whereas transvaginally, we can put the probe right up against the organs, and so we get a much clearer picture. And this goes towards explaining to the patient how it's going to benefit them. So this is where I sort of say, transabdominally, I see a vague fuzzy shape for an ovary, whereas transvaginally, I can count the follicles on your ovaries. And then we need to explain what is going to happen. And so my explanation of what is going to happen includes always, I'm going to insert the probe into the vagina. We need to be very obvious about that so that they understand this is an intimate examination. Whilst the probe is inside you, I need to move my hand around to get the images of the anatomy that we need. It's useful that our patient understands that as we're moving the probe around, that's part of the examination. I need to explain to the patient that we're going to test the mobility of the organ. So I may need to push and prod a little bit to get better pictures or to test and see if the organs are mobile. The test shouldn't hurt, it shouldn't be painful. And if the patient does experience pain, it gives me really important information that adds to the information of the examination. So the patient needs to understand it shouldn't hurt. And if it's painful, that helps us decide, is that what's causing and replicating their pain? And the patient also needs to understand that as part of informed consent, they can withdraw their consent or ask to stop at any time, no judgments. And so informed consent is the process in which the patient understands the why and how an examination may be performed, which is why we go into the detail of the probe will be inserted into the vagina and I need to move my hand around and push and prod a little. That's part of the normal examination. The patient needs to understand any associated risks, the costs and the benefits of the exam, and on that basis, whether they allow their body to be touched. The person consenting to or refusing an examination must be able to understand the information about the procedure so they can make an informed decision. And you may need to supply written material or diagrams or further explanation to make sure that your patient has sufficient understanding so that they can provide informed consent. Now, consent may be implied, be provided by gesture or verbally, and in some cases, it's required that it's written consent, which assumes that your patient can read. So the important thing here is the foundation of informed consent is that the patient understands. So whether that's because they've read it or because you've explained it, they need to understand what you're going to do. And a part of informed consent is them understanding that they can withdraw their consent at any time. So I have a very rigorous sort of step-by-step approach to getting informed consent. And I know that by the time I've popped the probe in, there have been 4 opportunities, at least for my patient to say no. Now, that's not necessarily what's mandated, but some might say that I overdo it a little bit, but I just don't think you can be too careful here. So my step-by-step process for informed consent is to explain the exam as I've already detailed in the previous slide, and I check and see if my patient has any questions. And once I believe they understand what we're going to do, I ask if they're okay for me to proceed with the transvaginal examination. I then send my patients to the bathroom to empty their bladder while I prepare the room and the equipment ready for the scan. And when they return, and before they are undressed, and after they've had a bit of time to think about what I've said, I just check and see, do they have any questions again, and are they happy to proceed? And based on a yes response, I then give them instructions for how to get undressed and how to position themselves on the bed so that we can do the exam. Now, once they're covered, I then ask again, are you happy for me to proceed with the examination? Which means I've now 3 times checked that they're okay to go ahead with the exam. And then I request permission to pop the probe in the vagina. Now, I always give my patient the option whether they would like to insert the probe themselves or would they rather I do it. Now, some people very clearly would rather do it for themselves. Other people are equally as embarrassed to do it themselves and would much rather I do it. It's an option that I give them. I just move on, do whatever they want as far as getting the probe inside. So I know that by the time I've started the exam, I've asked for permission to do the scan at least 3 times, and I've also requested permission to put the probe in the vagina if they would rather I do it or they do it. Now, it's important once you get scanning, often what I see, and particularly when people are just starting to do this and starting to learn the transvaginal exam, that ultrasound screen is like this wheel of hypnosis and this spinning spiral here, and people just get sucked into the screen and they forget that on the end of the probe is a patient who is experiencing an intimate or a intrusive examination. And so it's really important to, especially when you're first learning, to be very mindful of the power of that hypnotic screen and how it can suck your complete focus as you're trying to guide your way through this examination. And so what I really encourage is that you have to program into your routine scan process periods where you are going to check in visually and make eye contact with your patient. And so this is where you're going to pick up the non-verbal cues that maybe they're not okay. So if you actually look at your patient, maybe you can see that they've got really clenched fists, or they're really frowning, or you can see the pain on their face. So it's a really important step that you do break that hypnotic trance that you're in with the ultrasound monitor and check in visually with your patient. And you can program this into your scan. So I tend to put the probe in straight away, just check in visually with the patient. And this also makes the patient feel like that they're part of the exam and that we're at least paying attention to them. I then scan the uterus and do the uterus, cervix, and endometrium, and in longitudinal and transverse, and then I check in with them again. And then I go over to the right ovary and check again after I finish the right ovary, or just check in if I need to poke and prod a little to find a different window to get better contact with the ovary. I'm going to check in with them just before I do that. And then again, the left ovary, check in visually before ending the exam. So it's a really important step, and I think it's really important to make sure that your patient is aware that you know that they're there and that they feel like they're safe, and that it's not you're not going to miss that they're in pain, or you know, whilst you're looking at the monitor and being absorbed and concentrating so hard. Now, the next step is to perform the examination. And so I tend to look at this as 7 separate steps. The first step is inserting the probe and finding the lie of the land, if you like. The next thing I do is find home base, which is the midline sagittal picture, or a longitudinal image of the uterus, all the way from the fundus to the cervix, to find the lie of the uterus. I then scan through the cervix separately. I scan the uterus, and then I do another pass and scan the endometrium. Then we go looking in the right adnexa at the adnexal structures, including the ovary, and then scan the left adnexa and the left ovary. So let's go through each step now. When I'm inserting the probe, it's important to think about where that probe ends up and to be paying attention as you insert the probe, so that you can see whether that uterus is anteverted or retroverted. You can judge when you have enough contact with the patient. So once I've got permission from the patient to proceed, I just gently place the probe at the introitus, and then I look at the screen to insert. And the reason that I do this is so that as I'm inserting, I can see the urethra and the bladder, and I can figure out where the anterior anatomy is, and I can determine whether the uterus is anteverted or retroverted, and get the lie of the land as I go in. So we start with the probe at the introitus. I want to keep the probe parallel to the bed to give me the best option to be able to determine whether it's an anteverted or retroverted uterus. And then as I look at the screen, I'm inserting the probe. If the uterus is anteverted, I'll need to put my hand down so that crystals are pointing anteriorly to see the fundus of the uterus. And if the uterus is retroverted, I need to put the probe hand up. So just one moment, I've got someone here who is a bit, just want to, can I get you all to just mute the your sound, please? Okay, so here's an example as we are introducing the probe. you can see here with the probe at the introitus, here's the urethra and here's the bladder. And already you can start to see that this fundus is anteverted. Now, the tricky thing about the transvaginal exam is understanding when you're in far enough. And so you can only judge that by looking at the screen. So as we insert the probe, you can see that as the picture becomes clearer, I know when I have enough pressure on the probe. And so the anteverted uterus, as I was saying, the hand will go down so that the crystals or the ultrasound beam is directed anteriorly so that we can see the fundus on the anterior side or on the same side as the screen marker. And the retroverted uterus, your hand will most likely be up with the crystals pointing down or the ultrasound beam directed posteriorly. And the fundus will appear on the right-hand side of the screen or on the side that is the non-probe marker side. Here's a live video of inserting the probe for an anteverted uterus. So we're at the introitus here, and as the probe comes in, you can see the fundus on the same side as the screen indicator. And here's a retroverted uterus. The bladder is still anterior here, and the fundus is pointing away from the bladder. Now, a really common problem, and certainly when I first started scanning, I used to get lost all the time. And the problem was I came in at a bit of an angle and I'd go into the posterior fornix, and then I'm getting beautiful pictures of bowel, but I see no uterus. And the only thing you can do here is to reposition your probe, withdraw the probe a little bit and try again. Make sure you come in parallel with the bed and see if you can see as you insert where that fundus is. So here's an example where the probe is in the fornix and all we can see is the bowel in the background here, and the uterus is actually sitting right up here on, oh, my cursor's going everywhere, right up here on the left of the screen, and it's out of the field of view because we're directing the probe quite posteriorly here. Now, as I was saying, it's really tricky to figure out whether you're in far enough. And the only way you can do that is by looking at the screen. Once you have good contact, you just need to stop applying the pressure. If you put too much pressure on, you can't feel the probe bump against the cervix. It will just keep going, but your patient will keep going off the end of the bed as well. And so you can see here in this longitudinal, as we approach, this is not quite because it's a bit fuzzy, but as we insert the probe, the image gets a lot crisper and clearer, and then it's enough pressure. In the transverse picture, we can see here, the bladder is still visible. And so if we apply enough pressure, we actually squish what is left in that bladder. And for the ovaries, it's really important because we're bringing our probe into better contact with the ovary. And you can see on this picture, we go from this kind of fuzzy, vague appearance to being able to see those follicles. Now, step 2 is to find home base. So once we've inserted the probe, the first thing we're going to do is rock the probe to put the desired anatomy in the center of the field of view. And then we're going to fan the probe side to side, as in this right-hand image, to find the midline of the uterus. And you can see here, we want to have the cervix, the endometrium, all the way from the fundus, all the way through to the cervix here. And on this patient, you can see a nice example of a cesarean scar. Now, if you're not quite in the true longitudinal or true sagittal of the uterus, as you scan through the uterus, you'll go through the fundus at a different time to the cervix. So I've illustrated a good example here on the left. We come out of the fundus and the cervix end at about the same time. Whereas if we're not quite in a true longitudinal position, the example on the right here, where we have the fundus first, and then we go through the cervix. So this tells me that I'm a little bit rotated. And it's not as simple as just rotating the probe to the transverse or the longitudinal. It's a much more subtle motion. And so what I want you to think about now, if you were to watch this action as you move the probe, it's hard to appreciate it. But I find if you think about this, and I've had successes, I've been teaching people, you can look and see, am I missing the fundus side or the cervix side? So I can figure out, is it the probe marker side and my thumb side, or is it the finger side that I can't see? Then we'll hold one side of the probe still and just gently rotate the other. So in this example on the left, you can see the fundus and the endometrial fundus here, or the fundal endometrium, I should say. We're missing the cervix. We don't have that line running all the way through to the cervix. So in this example, the fundus is on the same side of the probe here, as the same side as the screen marker, which is where our thumb is. If I hold my thumb still and think about gently pivoting my fingers or rotating just the finger side, then you'll see here that the cervix comes into view really nicely up here. And there's our longitudinal all the way through. So that's the true longitudinal of that uterus. And on the right-hand image, we have the cervix here, but not the fundal endometrium. So if I hold my finger still and very gently pivot my thumb, I can join it from the cervix all the way through here to the fundus. So a true longitudinal image has the endometrium visible as a thin line, or depending on the stage of the cycle, all the way from the fundus through to the cervix. Once we've got that longitudinal, just note where your thumb is. Is it at 12 o'clock or 11 o'clock? Because that will tell you where the axis of the uterus is for when you're scanning through. Now, I scan the cervix as a separate pass. I've recently had a number of inquiries. I think there was a case just recently where a cervical scar ectopic pregnancy was missed. And the question was, how do we avoid missing a cervical scar ectopic? And the answer is you have to actually scan the cervix. And you have to scan the cervix and adjust your probe position so that you can focus and concentrate on the cervix. So once we've got that uterus, what we're doing is rocking the probe to find where the cervix is. So if it's an anteverted uterus, your hand will come up and direct a little more posteriorly to see the cervix. And if it's retroverted, it's the opposite. So you can see in this example here, we can see the cervix and the midline coming all the way through here. There's a couple of little Nabothian cysts here. And then what I need to do is fan from side to side to scan through the cervix here, all the way from one wall here, through the midline and out to the other side. You can also test the mobility here if you're looking for deep infiltrating endometriosis. You need to just think about positioning your probe in the posterior fornix. So you have to push down a little bit and advance it ever so slightly, and then you give it a bit of a poke and a prod. And what we're looking for here is the bowel sliding over that posterior lining of the cervix here. So as we're poking, you can see everything slides freely here, which is a normal positive sliding sign. So if it's not sliding, that's indicative of some scarring from endometriosis. So after we've examined the cervix, we look at the uterus. And again, now we're just shifting our focus a little bit. So we rock to position the anatomy that we're looking at in the middle of the screen. And you can see here on this example, here's a cesarean scar. And so we can see all the way from the top of the cervix, all the way through to the fundus without cutting off any uterus here. So we know we're in the right position. And then we need to move our hand from side to side to scan through to one lateral boundary and then all the way over to the other lateral boundary. And then rotate our probe. So thumb goes to the 9 o'clock position and we're scanning here from the cervix or the lower uterine segment all the way to the fundus and beyond the fundus so that we end up past the uterus superiorly. Again, we can test the mobility. So back here in the longitudinal image, I'm just going to check in with my patient and let them know I'm just going to poke and prod a little bit. I'm testing to see if things are sliding as they should. So I put a bit of pressure, gently advance the probe. At the beginning here, I'm pushing the probe in and out gently. And at the end here, I'm applying pressure over the top of the abdomen. So at the beginning here, we can see this is sliding across the back. And then now, pressure on the tummy, we can see it sliding up here. So there's no signs there of any infiltrating endometriosis. Then I do another pass where I just focus on the endometrium. So this is where we need to bring our depth up so that we make the endometrium bigger. And once we've found our midline picture, we can measure the thickness of the endometrium. And so what you need to do is measure the widest point of the endometrium, and that measurement should be parallel to the lie of the endometrium at that point. So if I was measuring here, you can see the lie of the uterus is here. If I was measuring this bit, the line would be a little bit more horizontal. And so the measurement would come more vertically here. And it depends on the stage of the cycle, what you're going to see. So this is just after period. Here we have a proliferative phase endometrium. So you can see the trilaminar appearance here. And this third picture here is the secretory endometrium. So the measurement is from the edge to the edge. If there's any fluid in the middle, you don't count the fluid in the middle. You can see the thickness here, perpendicular to the lie of the endometrium. And here is where we would measure it in this secretory phase endometrium. Now, for those of you who are scanning patients with an IUD in, you'll notice the very bright echogenic IUD in the midline. So as we scan through, you can see just through here, and there's reverberation off the plastic. So we can see that it's in a good position in the fundus of the uterus. And in the transverse orientation, you can see the little echogenic flip there with the shadowing behind it. And as we get up to the fundus, you see the sort of horizontal wings of that IUD. Now, the next step is step number 6 is to scan the adnexa. So my home base position for finding the right ovary is to come to the fundus of the endometrium, identify the broad ligament or the cornu of the uterus, and then the broad ligament following on from that. So I come up to the fundus. I'm going to position my probe by rocking it so that I have the edge of the uterus on one side of the picture and the iliac vessels on the other side. This means I have the whole adnexa in view, and then I'm going to fan through. So my hand will move up and down to fan through the adnexa in the transverse plane. You can see on this clip, we find the fundus of the uterus. Then I position by rocking the probe, put the uterus over to the side, find the cornu. So at the fundus, you can see the sort of pointy ears here. Position the uterus, so rock the probe, find that broad ligament. Now the next step is, once we've rocked, is to fan up and down. You can see this ovary sitting in here, and here are the iliac vessels. So uterus on the edge, we've got the whole adnexa in view, and we're going to fan through to find the ovary. It's important to remember to adjust your depth when we're looking at the ovaries. They're often a lot closer to the probe. And so you can see here, as we adjust our depth, how the image improves and how much clearer it makes it to be able to see the ovary. So just bringing the depth up a little bit, it also means that the focus is at the right spot and we get a much clearer view of the ovary. Now, I talk about following the broad ligament. You can see where the uterus here comes to sort of a triangle, if you like. In this region here, we're going to see the broad ligament, and that's kind of like the hypoechoic brick road to the ovary. So and that's in a 3-dimensional plane. It will change depending on where you're fanning, but if we follow those blood vessels and that tissue out, we often will find the ovary at the end, sitting medial to the iliac vessels. So as you can see in through here, just at the end of the loop there, we can see the ovary more clearly. If I'm scanning through the right adnexa or the left adnexa and I don't see an ovary, and I have done a very thorough search, then I label the image the right adnexa, which tells me I've had a damn good look, but I couldn't find it. And sometimes that happens. Now, we also need to test the mobility of the ovaries. And again, we just give the probe a gentle poke and a prod, and you can see that everything's slipping all over each other here. That's the right ovary. And here on the left, you can see a gentle poke and a prod. You can see things sliding over, and you need to sort of adjust your position somewhat to get the ovary to move. Now, this is a useful test if you're concerned about an adnexal mass. Is it on the ovary or is it in the adnexa? If the mass and the ovary move together, they are adhesed, and if they slide separately, they will move separately and you'll see them slipping and sliding over each other. For those of you doing follicle counting, you need to scan through the ovary very slowly in both planes. And what I do is I start from the lateral edge and then fan all the way through to the medial edge or vice versa. And I'm counting as I go. So here we've got 1, 2, 3, 4, 5, 6, 7, 8 follicles. You then do it again. And do I come up with the same number? And so as we are scanning through here, you can see as I make those slices, I will see the follicle just here. I get in a couple of slices as I'm seeing through, as I'm scanning through. And this is how we go about counting the follicles. I then need to go into the other plane. So we're going to do the same thing and repeat it on the same ovary. And in the other scan plane, going from the top to the bottom, where you're going to move the probe and count as we go. And it should come out as the same number as what you saw in the original scanning plane. So if you're starting in trans and your ovaries in a longitudinal scan plane, then when you move to the longitudinal section with the ovary and long, it should be that the follicle count is the same. And so as we move through here, you can see that we will see the different follicles as we're moving and we count as we go. And the last step is to go and do the other side, and it's repeat the same thing on the left side. Now, if really having trouble finding the ovary, what I do is I'll go, let's say I can't find the right ovary. I try and scan through that adnexa. Can't find it, go to the left adnexa. I just need to ease off the pressure a little bit, reposition the probe into the left fornix, advance the probe gently, see if I can find the left adnexa, then come back and try again on the right. And sometimes what happens is just with that moving around, you're in a slightly different window, and so you get a better look and you might be able to see the ovary on the second attempt. So you can see here as we scan through, we can see that ovary come into view. Here's the broad ligament, the ovaries here, and as we apply a little bit of pressure at the end there, it gets much, much more clearer. So those are the 7 steps that I go through. First of all, insert the probe, and we need to be very careful as we're inserting. We're watching the screen so that we can see if it's anteverted or retroverted and get an overall picture of the pelvis. Is there any free fluid? Then we're going to find home base or a midline sagittal image. That's the place that we come back to. So if we're getting lost, come back to this, take a deep breath and try again to find what we were looking for. I'm going to scan the cervix separately to the uterus, separately to the endometrium. I do a pass, like a whole scan of the uterus, essentially 3 times in both planes so that I concentrate on different aspects. It's too much to take in one picture. We're going to then scan the right adnexa. And if you do the left adnexa first, it really doesn't matter. You're going to scan one adnexa, looking at the broad ligament, the vessels, and the ovary and any structures that are in the adnexa, and then come over and scan the opposite adnexa. So that's what I've got for you for today's episode. I hope that in amongst that, there's been some really useful tips that you can try when you're scanning transvaginally next week. You can be just trying to practice doing that pivot motion or practice keeping your hand steady and solve one problem at a time. If you're looking at the image and it's not quite right, I want you to think about what's not right about this picture and then think about how you're going to problem solve it before you test it and see if it worked. And when you test to see if it worked, it's move in one plane or another so that you understand the action and consequence of your probe movements. So if you found this episode helpful or useful in any way, feel free to refer your friends and colleagues to the resources section on our webpage. Now I get to throw it over to you if anyone has any specific questions or any comments, anything they want to share about their successes or troubles in a transvaginal ultrasound exam.
Yes, thank you very much for the presentation. I think it is very brilliant. And the most difficult thing this way will remain getting the patient's consent. Yeah, so some patients will refuse, some will say that they are still virgins, some some will say that they don't want an opposite sex, and some will say they don't want it at all. So I think that is a challenge that we have at this part of the world. Thank you for the presentation.
It's easy for me as a woman to say that getting consent to do this type of scan on a lady, I've only ever had a handful of people in my whole career, a handful of people that have refused this test. And I put that down to good explanation of the examination. But I know I learned from a male sonographer, he never put a probe in because he said that was part of the consent process. If they're putting the probe in, it meant that he felt he was less inclined to be accused of something because they've put it in the right spot. I do appreciate that being a guy doing this examination is a very different kettle of fish. And I think that, you know, the question of whether you have a chaperone for the exam, you know, that could help. But sometimes that can be more intimidating because it's more people looking. So, you know, I think good communication is helpful, but sometimes if they say no, the answer is no, and just get the best pictures you can transabdominally.
Yeah, thank you. And what we have tried to do is that sometimes we bring a female colleague, at least we are two of us, and or the patient's caregiver, as you have said, so that they can accompany the patient. And you make sure that the patient has understood what you have explained and how the procedure is going to be done.
Yeah. The role of a chaperone is not only for the comfort and safety of the patient, but sometimes that's for your protection as well. You know, there are some patients that are, dare I say, a little bit strange. And I know there have been a few patients that I've kind of felt, I think I need a chaperone because the patient was a bit strange. It begs the question, do I even bother to proceed if I've got that feeling from the patient? But it's important that that chaperone is there. They're supposed to be someone who understands what the procedure entails. So, you know, having the patient advocate or the patient's family member doesn't necessarily provide chaperone. It should be someone who is also medically trained, because they're there to defend you as much as to attest to the fact that the examination has been performed in an appropriate fashion.
I may have just this one concern. So sometimes a patient is bleeding profusely and cannot keep a full bladder. The doctor just comes in that he needs to know what is happening. So is it contraindicated to do a transvaginal ultrasound when the patient is bleeding or not?
No. So for a transvaginal ultrasound, I'd always empty the bladder immediately before I go, because the full bladder pushes the uterus deeper in the pelvis and away from the probe, so you don't get as clear pictures. But the examination can be conducted while the patient's bleeding. It doesn't affect the exam at all, but I do appreciate for the patient, like if they're having their period or something, it can be quite uncomfortable, and they might feel quite self-conscious about it, but it actually doesn't affect the scan. As long as you have good probe cover on and you take good precautions to do high-level disinfection of your probe, there's no problem if the patient's bleeding. And I've certainly scanned many patients in my time that are in the middle of a miscarriage, for example, or having their period, or they've presented with menorrhagia and they need to investigate why they're bleeding so heavily. So from our perspective as the operator, it doesn't affect whether it's possible to do the exam, but I'm always very conscious that for the patient, it might be quite uncomfortable. And so again, here's where those communication skills come in handy and where you have to, you know, allay your patient's anxiety about such things.
Oh, hi, Sue-Ann, it's Donna. Just a quick question. Just in relation to anteverted and retroverted uteruses, can you just quickly explain the anterior and the posterior when you're doing a transvaginal scan?
So when you put the probe in, you come in horizontally, okay? Yeah. So when you come in horizontally and you see whether the fundus of the uterus is on the anterior side or the posterior side. So if my thumb is sitting on the same side as the probe marker, the side where my thumb is here, or the probe indicator, you can see the little one, the screen indicator is going to be left of screen. And so you can see as we come in, the bladder here is anterior and an anteverted uterus folds towards the bladder. And so if you look at this image, that's kind of what you see, but then it turns over and it displays this way. So when we've got it displayed this way, here's the screen indicator, which is demonstrating the anatomy that's closest to your probe marker or your thumb. So this side of the screen here is anterior and the bladder, oops, I've got my pointer going here. So this side of the screen, here's your screen indicator. This side of the screen is anterior. The bladder sits over here. And so here we have the fundus folding or pointing to the anterior side. When we go retroverted, bladder is still anterior and on the same side here as the screen indicator. And so the image, the uterus looks like this. And then when we turn it sideways for how it's displaying, our screen indicators up here, this is anterior. The bladder will sit here. And the fundus is now pointing away from the bladder. So that tells me it's retroverted. If you go through the process of understanding it, your screen indicator in the longitudinal scanning plane is anterior, and the bladder should be on the same side of the screen as the screen indicator. So I think as we're coming in here, if I show you this image, you can see this is with the probe just in the introitus. So we've just put the probe in so it doesn't fall out. It's just in far enough. Then I'm going to look at the screen. My screen indicator is here, and that's representing the anatomy on the side of the probe of the thumb, and my thumb's pointing towards the roof. You can see here urethra, and here the black bit here is the bladder. And so this fundus is pointing towards the bladder. And on this side, here's the screen indicator, here's the bladder, that's anterior. But now our fundus is pointing away from the bladder. So it's pointing posteriorly or on the same side as our fingers as we're holding the probe. And so if I just push the go button here, as you come in here, you can see the uterus a little more clearly. And then on the retroverted, as you insert, you see the fundus coming up posteriorly here. Does that make more sense?
It does. If you see a lesion, say a small fibroid in the posterior myometrium on a TA, and then you go to the TV, but the uterus is retroverted, will that posterior myometrial fibroid be still on that posterior aspect?
Yes. So here's anterior. This is the anterior myometrium. This is the posterior myometrium, and here is rectum along here. Bladder, anterior myometrium, posterior myometrium, rectum.
Yes.
So the posterior lesion shows up here.
Yes, so it's reversed. Yep.
Yeah, essentially. Like it's all back to front. And then your hand's moving opposite as well. So, you know, if you're retroverted, your hand is going to be up with the crystals pointing down or the ultrasound beam pointing towards the bed. And the anteverted uterus is the opposite way. Your hand will be on the bed with the crystals pointing up or pointing anteriorly. So all the hand movements are opposite to get everything in the middle as well, which makes it very confusing.
Yes, no, that's perfect. Thank you, Sue-Ann.
No worries. Any other questions there? Well, thanks so much for joining me, folks. It's been great having you along. I hope you found that really helpful. Go and practice one thing this week. Try and sort out one of those problems that you're having. Just practice that thing and try to think your way through and problem solve it so that you understand it. It's kind of like your maths when you're at school. You know, you can't just learn it all by rote. You have to understand how to do it. So the more you can concentrate on problem solving this so that you understand what's happening, the easier that all comes together in your head eventually. So I will say thanks for joining us. Hope to see you again next month. If you have any questions specifically for next month, I'm open to suggestions for next month's topic. So just get in touch on my email, suanne@ultrasoundtraining.com.au. Otherwise, that's all, folks. Thanks for joining me.